Welcome to ASCP's Health Plenary on the Futures. I'm Dr. Blair Holliday. I'm the Executive Vice President for ASCP. And it is indeed an honor to be here with a distinguished panel today to discuss what we feel and hope will be quite an adventure for you and an experimental session for us, because we're trying something that we've never done before. When you think about that, we have a couple of folks here that are outside of the field of pathology that are going to help shake it up for us. And you're going to see how we do this, which is a little bit different from typically how sessions on the future are run. It's all stemming from a conference that we had several months ago. Can you cue up the first slide for me? Next slide, please. So, Pathology's future began when you all started practice. We started thinking about what happened over the last several years as it relates to personalized medicine, and we realized that this organization needs to take a more proactive role and look at opportunities that could possibly forge the future of your practice, and we did that under the auspices of a grant that we got from the Abbott Foundation. Well, this conference brought together leaders, and you can see a picture of these folks here, from different areas of healthcare industry, and the panel was basically designed to help us create that paradigm or that exposure that we could determine if, in fact, you could be a player and we can help you be that player in order to do several things. Number one, improve patients' outcome, but do that under the guise of a very proactive future. A laboratory efficiency and patient outcomes, they go hand in hand. But unfortunately, it won't occur without high-quality health care and accessible health care nationwide. So there's been several task forces that the ASCP has been involved in. I'm not going to go through the litany of these, but I'll start at the beginning and just tell you that as far back as 2005, the soliloquy of task force has been framed around what we refer to as the future. Starting back with Jack Brooks and looking at strategies, how we can begin to design a very proactive role in the future. Now into 2006 and 2007, when Dr. Hilborn was working with us on external perceptions of our particular field and how we can influence those external perceptions, particularly the clinicians. We did many, many interviews across the nation, and we began to develop what we saw as an emerging theme, and that emerging theme was a report that was emanated from that task force. So here are the conference topics that emerged from our Futures Conference, and you're going to see some of these topics touched on today, but we're not going to go into all of them. But I want to summarize a couple of points for you. Number one, the development and the role and the impact of new technologies in our profession is dramatically emerging, and we are in an age where we're going to have to be part of the solution. And if we're going to own that space, we have to decide how. Increasing involvement in patient care delivery and the guidance and the development of medicine is going to occur many, many ways, but personalized medicine seems to be the buzzword of the day. Personalized medicine, genomics, informatics, all these are merging together into a paradigm that we feel is absolutely essential for the future of our practitioners. Employing and using this laboratory data in order to prevent things such as overutilization of laboratory tests, particularly under a capitated system that's coming down very rapidly in healthcare reform. And then, of course, all global efforts to ensure that international standards and quality are protected. So we're going to play a central role in the following areas. And the first is HIT, or Health Information Technology. What does that include? It includes areas, of course, in informatics, electronic health records. How is pathology going to play a central role in that? What can we do as practitioners in order to make sure that we, in fact, protect the patient? And that merges right into error reduction. And error reduction and comparative effectiveness research is the area for which this organization will be focusing a great deal of its activities. In fact, we'll be launching a Center for Health Services Research that is going to be centered particularly around how we can guide clinicians and our practice to prevent overutilization. Clearly, new technologies will play a key component in this. Well, Molecular diagnostics, as we know, is one of those areas that we would like to continue to practice in, but it's emerging so quickly and rapidly, particularly in the age of whole genome extraction and analysis of all the component parts of DNA, that we have got to step up to the plate and decide if we're going to be owners in this domain. And the health system changes, particularly as healthcare reform is in front of us and the accountable care organizations, or ACOs, help mandate where and how we're going to be funded, is going to be a huge impact in how we practice and how we staff our laboratories. And then lastly, the public health concern and making sure that our clinical laboratories do interface on the public sector and do interface in a mechanism that is driven by the sector of the patient that we refer to as public health. So questions to address in the future emerged. And some of those things that we discussed were the following. Who's going to transform pathology? Who's going to own this? And how are we going to help the advancement of that cause? How can pathology organizations lead? How can we work together with other organizations, particularly in a federated manner, to make sure that we, in fact, are speaking for the profession collectively? We don't practice in silos, and neither should organizations. And what can we do in the next year to advance the cause and help with the solutions to make sure that laboratory medicine, in fact, is facing the future today? We have to establish a more proactive leadership for pathology. And we can do that, but we have to do that by looking for transition and transformation. And these are the buzzwords that you hear a lot these days, particularly as we forge ahead with these new initiatives around personalized medicine. So recommendations that emerged out of this conference were the following: that it's agreed that there's a shared vision on what we need to do is what we have to balance around what's best for the patient. And we've got to step outside of our comfort zone, and we've got to be prepared to promote those products and services that meet the patient's need. They meet the needs of what's best for the patient. It's got to be outcomes-based, and it's got to be under the factor of how we determine what best data is used. And engage the decision makers. And those decision makers are from myriad sectors of our environment, from hospitals to the government, from the community, all in order to improve that internal or external perspective and demonstrate that we, pathology and laboratory medicine, is a service, not a commodity. So the imperative that began to emerge was that proactive leadership will help drive that transformational change. Active participation in the healthcare decision-making team, being prepared, being outspoken, and as Dr. Mark Stoller said so eloquently in his opening address, be prepared to speak up. And doing so will help us close those gaps in the healthcare system all the way from test utilization to health information systems. And remember, each of the things that we do are going to be scrutinized. And they're going to be scrutinized under a system of cost effectiveness, or a system of healthcare of cost effectiveness. We have to drive the data to determine how, in fact, we can influence and work with our third-party payers at AL to make sure that that system utilizes pathology as the backbone of its decision-making. So today's panel is sitting on the stage for you, and again, this is a vast array of experts from different panels and different walks of the healthcare sector. Now, again, not necessarily only from pathology. Let me introduce some of them. Dr. Mark Stoller, our current president, who serves as Associate Director in Surgical Pathology of Cytopathology at UVA. And you've had an opportunity to hear his message and his leadership focus, particularly as it's governed around patient-centered advocacy and how pathology and laboratory medicine must evolve in order to meet that patient-centered advocacy. Dr. Stoller, if you'd raise your hand, please. There you go. Dr. Steve Bernstein, the Director of Quality Management, the program at the University of Michigan Health System. He works in the area and helped us in the area of how can pathology be involved and influence health systems, and particularly how we as an organization of practitioners can help influence that system. Dr. Bernstein. Jeff Jacobs serves as our Vice President for Public Policy and Advocacy. He's in our Washington office. Jeff Jacobs spends his days tirelessly looking and working at angles in order to improve the healthcare system and make sure that this organization and other organizations work together in a collaborative fashion in order to drive that impact and hopefully control that impact. Jeff. Dr. Robert Brook, who is Vice President of the RAND Corporation and Director of RAND Health, will be talking to us today about leadership training and why we in this community of scholars have to be more intimately involved in leadership. And we're going to have to do this by looking at social determinants of health and how we can help influence those impacts. But remember, it isn't necessarily in a silo. It has to be done in concert with our clinical colleagues. He's going to be talking to us about several of those impacts. And last but not least, I thought I was going to be appropriately upgraded on my dress today until I met Dr. Cominski when he showed up. And Dr. Cominski, who is here as a special guest, past president of the California Society for Pathologists, who is in Palm Springs Pathology Services in Palm Springs, California, also past president of the American Society for Cytopathology, has worn many hats and forges a very proactive approach at interfacing the patient and the future of pathology. He's going to be talking about a very unique, special way for which his practice has evolved in the role of direct patient care. That's right, you heard that right. Direct patient care for pathology. Dr. Cominski will be sharing those thoughts at the end of this presentation. Dr. Cominski? So, I'm going to introduce the first speaker. Each of the speakers is going to speak to us for about 5 to 10 minutes on their goals and how they see the future of this organization, the future of our profession, and the future of our collaboration with other organizations impact the future of pathology and laboratory medicine. And they're going to do that under the guise of what they consider to be a very proactive, forward-thinking manner. And the first person I'll introduce is, in fact, our esteemed president, Dr. Mark Stoller. Mark.
Thank you, Blair, and thank you all for coming. I hope after the presentations this is set up that we have more of a conversation. And as you notice, I'm working without a net. No slides, no iPad, no nothing. And I'm doing this because we've already in part had our conversation about, from the ASCP's perspective, where and how pathology has to focus its effort in this environment where there are, shall we say, more external pressures and threats than we've ever faced before. The process that Blair outlined, this systematic process, this series of task forces that have driven the vision that ASCP is bringing forth that we talked about of patient-centered advocacy, about focusing everything we do through the lens of what is best for our patients, regardless of how it impacts ourselves in terms of practice, particularly practice income, and the utilization of tests in a clinically valid and patient-appropriate manner versus the overutilization or inappropriate utilization or lack of validation that is somewhat rampant in medical practice. It's often quoted that 30% of the healthcare dollar, 30% of the healthcare dollar is being wasted because of the combination of overutilization and inappropriate utilization, not so much in pathology and laboratory medicine, but in medical practice in general. So I hope that what you get from this is that we have taken a very careful, systematic approach, developed this strategy over the course of more than 5 years, and this panel tonight and the report that is in your bag, which I hope you've all taken the time to read or will read, be stimulated to read after this conversation, is our continual testing of the waters, if you will. We want to be sure we get it right because we're going to be interacting with all of you in a continual fashion, driving your education, transforming the nature of education at the ASCP, both in its annual meeting and in its myriad ways of educating continuously throughout the year to help give you the tools that you need to cope with these pressures that I think we're going to have a conversation about tonight in the panel. So why do we think this is so important? We think this is so critical at this juncture because, as you know, healthcare in this nation is undergoing a system of reform, and I believe Jeff Jacobs will describe some of those elements of pressures that are as long as the healthcare reform bill still exists, and after next Tuesday, we'll see if it's going to we predict it exists or not. So that's really all I want to say. I want to say that I want to thank you for your for coming. I also want to thank you for your engagement. We're looking to you, all of our members, to be engaged not only in this conversation, but in this process of modifying, improving, extending our practice to reach beyond what we have traditionally done, to evolve in a way that will allow us to thrive in what everybody predicts is a changing environment of practice. So without further ado, I guess we'll have our next speaker, it's Dr. Stephen Bernstein.
Good afternoon, and it's a pleasure to be here to speak with you. As you heard, I'm a general internist, and what I was asked to talk about is what I, as an internist, would need from you as pathologists. And, whoops, if we can go back. It really boils down to these points. I want you to provide tests for me that are appropriate, they're safe, they're timely, accurate, easily obtained, transmitted correctly, integrated with other information, and of course, they're inexpensive. If you can supply that, you'll make my day. You'll make the days for my patients as well. But I want to bring this to a clinical sense, and so this is just, a patient to think about. WA, 66 years old, he's anxious, he's got a bunch of medical problems, lives in New York, has a house in the Hamptons, comes out to LA occasionally for doing work on movies, he's got doctors all over the place, and he gets a lot of different tests done. And when he gets these tests done, they get done, and done, and done. So in March, he had an LDL-C and a C-reactive protein in New York, and in April, he had a point-of-care A1C in the Hamptons and an LDL test. May, he's in LA. Guess what? They order the tests again. Just keeps getting all these different tests done. Well, the critical question that I ask as a clinician, and that you should be asking as pathologists, is all that testing necessary? Do we need it for screening? Do we need it for diagnosis, for management of the patient? Are we ordering the correct tests for our patient? Well, there are guidelines out there to tell us what to do. They're developed by clinicians, and often pathologists are not part of the group who are helping to develop those guidelines. But guidelines are helping to drive medicine today. Guidelines are favored by insurers and payers to reduce costs. Dr. Hilborn told us that earlier this afternoon he was doing battle with Blue Cross for you in terms of cystic fibrosis testing, where they're refusing to pay for genetic testing on that. Specialists need it to guide care. Hospitals want it to reduce costs. You're going to hear Jeff Jacobs talk about accountable care organizations and packaged care. So you as pathologists in your society has to influence that test ordering. You've got to become part of the decision-making process to consider what the evidence is of the impact on clinical decisions and work with agencies to develop these guidelines. Just before this meeting started, Mark Stoller and Bob Brook and I were talking, and Mark said, well, we're going to have $500 genomic testing. We'll know everyone's gene panel for $500. And Bob talked about one of his colleagues at UCLA who's got this spectrograph machine that can put on an arm and identify proteomics, what all the proteins are. Well, we're going to be loaded with information, and what do we do with it? And how do we handle that information? It's something we all need to consider. I'm not going to really go into much, where is the test done? Well, obviously, as I said, we want tests done conveniently and easily, so point of care is important. But then what's the role of point of care versus centralized analysis? So at my institution, we do point of care A1C testing. It seems to be a good test, accurate, timely. We disagree with our cardiologists. My cardiology colleagues do point of care LDL testing. My general internist colleagues won't do it because you need volume for it. You can't do a finger stick. You have to do venous blood samples. And so because of that, because of convenience, because of workflow issues, we've reached different decisions about that. But where you need to think about this is really as we're talking about these different types of tests, where they're being done. Are they being done in centralized labs? Are they being done in these little boutique labs for proteomics? Where is the best place that they should be done? And what I would argue for your society, for you as professionals, is really to think where is the best place for it to be done. And the best place means where is it going to be done most accurately and most timely for the patient. I'm not going to really talk at all about this area because this is your area of expertise. You know what the sensitivity is, the specificity, how to process your samples accurately. But that post-analytic phase really does become a critical element in terms of the results being sent. I use the example for Woody Allen of all those tests being done, and yet no one was talking to each other. The doctor in the Hamptons didn't know what was being done by the doctor in New York, who didn't know what was being done by the doctor in Los Angeles. So they were repeating these tests, which really wasn't necessary for the patient's management. I only mentioned 3 doctors that Woody Allen might have. This is data from Medicare that for the distribution of our patients in terms of the number of chronic diseases they've got. This is Medicare data from 2003. About 10 to 15%, 18% of the population of Medicare beneficiaries has 2 or more of these chronic diseases. Now, how many doctors do they see for these chronic diseases? On average, if a patient's got diabetes, heart failure, and CAD, they're seeing an average or median of 12 physicians. And yet, if those physicians don't talk to each other, if the lab test that they're each ordering isn't communicated, they're going to be getting those tests repeated time and time and time. So a problem is I don't communicate with my colleagues about what tests were done, and yet laboratories don't communicate with each other either, and that's a problem. What we need to do is we need to transmit this information so it's available to everyone. When I order a prescription for one of my patients, regardless of where he gets his prescription done, if he's got health insurance, regardless of which doctor orders it, it goes through a pharmacy benefits manager. Every prescription gets hit against each other. Yet for pathology, when a patient gets a test done, they're in their little silos. There's no central clearinghouse. And I would argue something your society and your organization should work on is a central clearinghouse. So we don't need to be repeating these tests and don't need to be duplicating the work. And why is this important? Because then you could reduce duplicate testing. You could increase my satisfaction as a physician because I know the test has already been done. I've got that result when I need it. And most importantly, you can improve quality scores for the physicians as we're all being judged on report cards, and you can reduce healthcare costs. And this is just really a lead-in for Jeff's talk when he's going to be talking about how accountable care organizations are going to become critical in terms of reducing our overall cost structure. And so how do I want to conclude? What I really want you to focus on is to think about what the unique value you as pathologists or pathology professionals brings to the question, and to think about what that unique value is. You're going to lose on the issue of the commoditization of pathology testing. Whether I get a sodium done from your lab or centralized lab, it doesn't really matter. It's a commodity. And what you really need to do is think about what that unique value is. And I conclude with 2 examples from other industries. How IBM reinvented itself. IBM, became famous because of its mainframes, and they would service those mainframes. And now I think over 75% of IBM's income comes from intellectual work, working with users to how to use that information. I trained in Pittsburgh, the home of the steel industry in the United States. And the steel industry kind of died in the US because it was cheaper to go to China to get steel made and even ship it across the country or across the ocean to make cars here. But what they've done is they've reinvented themselves to do specialized steel products that can't be made or can't be made as well elsewhere. And I think that's the direction you and pathology need to go in terms of trying to find that unique value for your services. And I'll turn it over to Jeff now about ACOs.
Thank you, everybody. I'm going to talk to you a little bit today about how we can implement the system that Dr. Bernstein is talking about and the system changes that are occurring today in the United States, healthcare reform, and the future of medicine. If we look today, we could look at a number of different changes. I think it's interesting, we can ponder for a second whether we're going through evolutionary changes, whether we're going through revolutionary changes, or whether we're going through necessary changes. And I put the French up here today, nécessité, because of what's going on in France today with President Sarkozy, who just raised the age of retirement to 62 from 60. And you see what's happening in the streets of France. And if we go back to Plato, we can say that necessity is the mother of all inventions. So there are no revolutionary changes. That's what I'm hypothesizing anyway. We're really looking at evolutionary changes and necessary changes. So if we look at the evolutionary terms of reform and what's been going on in the United States, probably since the 60s, you might go back further than the 60s, you can look at these terms. These are nothing new. Some of them are new to us because we haven't heard them before, we haven't pondered them before, they haven't been part of your practice. But this is what's been going on in those who have been working on change for a long time. So comparative effectiveness, we're now hearing a lot about personalized medicine, diagnostics, how we can improve those, how we compare those, what's more cost effective. Accountable care organizations, this is a new term. What is it? It's integrated health systems. It used to be maybe managed care systems. We're trying to look at large systems. It's part of the new system where you can actually follow a patient. You can follow them in the way that Dr. Bernstein outlined, where you're not just having somebody in New York do one battery of tests, someone in Los Angeles do another battery of tests. This is something that we can follow the patient. You can start to look at gain sharing or shared savings, where if you're actually saving money, then some of that money can be given back to the actual accountable care organization. It can be used as an incentive payment to providers and other healthcare professionals who are working in that system. I think Dr. Bernstein mentioned his need for this next one, a test utilization committee or a formulary committee. It's akin to a pharmacy benefit manager that Dr. Bernstein outlined. This is not that common in systems, as I understand from you, but it may be coming and could become more common, so that's something to look for. I know that now, I heard today that about 60% of all physicians are now salaried, so this will allow, even though fee-for-service is still driving those salaried physicians, as this moves up and ratchets up and becomes larger in percentage, you got more of an opportunity to move away from fee-for-service. So that's an opportunity and also a challenge for all of us and for the system itself. Pay for performance, you've been hearing a lot about this, and pathology has a lot that they have to do to come up with outcomes measures and the like to be a part of this pay for performance system. Value-based purchasing, which I think is summed up best by value over volume, and that's going to be a part of the healthcare reform system, and especially at the hospital level. And then bundled payments for episodes of care involving physicians, and moving more to a bundled payment system, and we're going to be looking at demo projects in the healthcare reform measure, and I'll talk about those in a little while because those are coming. These are the evolutionary implications for pathology. Again, nothing new here for you, I believe. Personalized medicine, molecular diagnostics, digital pathology, telepathology. Again, think about 10, 15, 20 years ahead. Incentives for reductions in unnecessary testing. That was, again, a little bit about what we talked about in gain sharing or shared savings, what they're talking about in accountable care organizations. The diagnostic wing of the medical home. I think you've heard a lot about the medical home and working with other clinicians, especially primary care physicians, and what role will pathology have to play in that, and we can be the diagnostic wing that can help improve care, reduce unnecessary testing. And complete integration into the clinical team. This is a real opportunity for pathology to really integrate into the clinical team, for you to be recognized for the good work that you do every day, to take our lab professionals and to raise them up and for them to be a part of this clinical team. Once you move away from fee-for-service, which is very scary, but once you move away from fee-for-service, there's many things that are possible, many, many opportunities for this field. I want to go a little bit to reality and where we're at today, because I think this grounds us, and why are we moving in this evolutionary fashion? If you look at both Democratic and Republican Congresses, 2003 to 2010, The Congress has kicked the proverbial can down the road and implemented overrided schedule cuts in the sustainable growth rate, which has now put us in a place that in December 1 of this year, physician pay will be cut by 23%. Now think about that. There's an election on Tuesday, and there's a cut due on December 1. I think that calls for a lame duck Congress. Do you think the Republicans, when they take over the House of Representatives, as they're projected to do, will want to have a lame duck Congress? So then CMS will have to do what they usually do and withhold payments for some time. But then you also look at a new Congress coming in, you're probably looking until February until it's fixed, until Congress can get together. And then it's going to require a bipartisan effort, or it's going to require the Republicans to, again, kick that proverbial can down the road. What does this mean if you look at the enormous costs? A 10-year freeze on the SGR alone is about $250 billion. If you look at a 10-year patch with minimal updates, you're looking at $330 billion. And if you fixed the system as it exists today, you're probably looking at $750 billion to just totally fix the system as we're operating today. These are enormous costs, enormous costs. And I find this very interesting. So let's go back for a second, think about those evolutionary terms for a second, and look at what the Medicare Payment Advisory Commission is looking at just this year. They're considering possible exemptions to SGR cuts. So look at this, multi-specialty group practice alternatives or a hospital medical staff alternative. If you look at these alternatives, you're starting to look at something that resembles accountable care organizations. So they're not exactly accountable care organizations, but again, possible exemptions to SGR cuts. Now let's go to what Henry Aaron wrote in the New England Journal of Medicine in July. And I'll read this. The prospect of allowing all or most of the fee cuts implied by the SGR to take effect could one day be used to encourage physicians to join accountable care organizations, promote acceptance of bundled payments, and elicit cooperation with other health system reforms. So let's go through the Affordable Care Act. Let's go through a timeline. If we look at this year, the Patient-Centered Outcomes Research Institute is now in place. It's been funded through stimulus dollars, and you're looking at $500 billion to do comparative effectiveness research. The National Quality Improvement Strategy by AHRQ is due to Congress in 2011. They're going to be looking at all of these system reforms that we've been talking about, accountable care organizations, pay for performance, quality incentives. This is an incredible linkage with everything that's been talked about before. Hospital value-based purchasing program is due to go into place in 2012, and a Medicare shared savings program utilizing ACOs, a demonstration project, is due to go into place in 2012. And then the dreaded bundled payment demo project that is due to go into place in 2013. And then the Independent Payment Advisory Board. This is really MedPAC with teeth. They will have increased power over time, so if you're looking at 2013 to 2018, by the time you get to 2018, you're looking at a very, very powerful independent board that will be able to make decisions about physician pay, about the health system as a whole. So we're looking at enormous changes. These are not revolutionary changes. These are evolutionary changes and necessary changes. So with that, I would love to turn it over to our distinguished speaker from the RAND Corporation, Dr. Brook.
On? Is the lavalier on? Can you hear me? All right. This is very easy. I'm going to tell you that pathology has not played at all in terms of having any trained people that really understand health policy and health services research, and it's a doggone shame. one of your past presidents, Lee Hilborn, was a clinical scholar at UCLA. Steve Bernstein is a clinical scholar was a clinical scholar at Michigan, and John Ball was a clinical scholar at Penn. But only one of them, I think, was a pathologist. The first thing you've got to do is make a decision whether you want to play it all. And if you want to play it all, you need some educated pathologists that know something about this field and just don't become political talking heads. So I would urge that you find 10 people or 20 people that are completing their residency in pathology this year and make sure they submit applications to the National Clinical Scholar Program, which are due February 1. There are 4 institutions that fund that have that program. Michigan, you can talk to Steve Bernstein, UCLA, Yale, and Penn. Number 1, do you want to play it all? At the moment, you've decided with your feet not to play. So you have to decide whether you want to play or not. I strongly believe that healthcare reform, these things that you've heard about, require significant physician leadership that know what they're talking about and can compete and talk to economists and statisticians and hold their ground in doing that. That's not happened. Second, that you have to decide what is your responsibility in medicine. You are going to be using, and I'm going to be using 10,000 new tests perhaps in the next 5 to 10 years. Some of them will be expensive. But the results that you report out will decide how extraordinarily expensive therapeutic tests are offered to people. Do you have any responsibility if the doctor who uses them, when Steve can't interpret your result or just ignores it and basically goes off and he's part of your organization and he screws up? Should you get shot? That's revolutionary, not him. Is it your responsibility to make sure that he understands your results, and if he doesn't follow them correctly with the patient in deciding what therapy to offer the patient, you're equally to blame as he is, or get equal credit if he does. So is it really the case that 80% of people on Herceptin don't have the receptor that is produced, I presume, by some of you, and get the drug anyway, and you don't care about it? Or do you care about it? The last thing I'm going to end you with, is there any need to have a pathologist in the United States? Any need. If I were speaking in front of a group of radiologists, I would argue that with a little bit of union busting, within 10 years, all of diagnostic radiology will be run overseas. Why not? We've outsourced everything else. What do you do that requires you to be in the United States and not available, and have backlogs of 2 weeks to do simple things that should be done in a day? With imaging and all the other technology, this is going to be revolutionary in medicine, not evolutionary in medicine, for one reason. The projections for the year 2019, the conservative predictions, are that by 2019, 20% of the GDP is going to be spent on healthcare. And the only group in the country that has not suffered in this last recession are healthcare professionals. The only group. We have not participated with the rest of the country in the suffering that has gone on. Why should they be nice to us now when they have to decide not to cut our salaries and our fees? We haven't done anything, as far as I can tell, during this recession. We've raised our prices, we've increased the amount we spend on healthcare. We haven't participated in trying to keep this country healthy and on a mission, because we don't seem to have any desire to do that. So you got a real set of questions in front of you, and I hope it's guided by a group of people that understand the social sciences that are needed to do this better than worse. I have a great faith in physicians. I want the healthcare reform to be led by them and not by social scientists and economists. You need to do your part, and I need to see some of your faces in training programs that actually give you the skills to do this.
Well, I want to talk about the pathologist at the front lines, and I believe that my practice in Palm Springs is a good model for how the evolution of pathology is going to positively affect all of us and what our role is in the future of medicine. I have lived and worked in Palm Springs, California for the last 35 years. For 28 years of that time, I was chairman of the Department of Pathology of a rather sophisticated community hospital that had an academic flair. For the last 6 years, I have been engaged in the private practice of pathology, working as a surgical pathologist and cytopathologist, but thinking like a clinical pathologist. And that's because my practice is patient-centered, personalized, and patient-focused. And it was an easy and intuitive transition to make. Some of what I'm telling you will be based on experiential evidence and some on direct evidence from other resources. But I think the model works, and I'd like to share it with you. 3 years ago, the executive board of the American Society of Cytopathology was challenged with rethinking and reformatting what the scope of practice should be for cytotechnologists in the context of HPV testing, HPV vaccines, and the expansion of cytology services such as fine needle aspiration biopsy. A consulting group was engaged to look at this comprehensively, and the report that was issued after a very comprehensive investigation was something that really went beyond the expectations or anticipation of the board, in that it really showed there was a necessity for pathologists to change in a changing world in order to retain a preeminent role in diagnosis and therapy. Why was this? Because the traditional linear care delivery model was breaking down. Generally, a patient consulted a clinician, the clinician ordered a test or a biopsy, the pathologist was responsible for processing and interpretation of that, and then a technologist in that laboratory was assigned the actual execution of the test, and a report was issued. What is happening now, and I think that this is derived predominantly because of patient education, because of their sense of identity as a health consumer, and because of their desire to have direct clinician care, is that the pathologist is becoming the interface individual with the patient in terms of explaining the diagnosis or because of interventional techniques. As pathology becomes more interventional, and many pathologists now are engaged in ultrasound-guided fine needle aspiration biopsies and in bone marrow biopsies and acquisitions, I think that the contact with the patient becomes very much reinforced, and one starts to understand that the patient is an entire entity who really needs direct attention, and that we are not any longer to be dealing simply in body parts or samples. What will happen in the future is that pathologists will actually be transformed from clinicians' consultants or the doctor's doctor to clinical providers. And some of this will be motivated by a physician shortage that is really quite imminent in this country. So given that, what should be the portrait of an evolved pathologist? The evolved pathologist really should transition focus from the laboratory to the patient, so that what happens in the laboratory is an extension or microcosm of what is there for the benefit of the patient. Strong patient interfaces get established through interventional procedures, through direct consultative services, and direct patient education. Some of my patients consult me specifically to explain the meaning of tests that their clinicians have ordered and don't know why they ordered it or what the meaning is. So they will bypass the clinician in order to have a direct consultation with the pathologist and walk away feeling much more satisfied and educated. The evolved pathologist has to adapt new technologies directly to patient care, not just offer the technologies as a test menu and be engaged in all of the sophistication of the new technologies, but actually to take meaning out of those technologies and apply them to targeted therapies, prognostic indicators, and things that are actually going to benefit the outcome of patient care. The evolved pathologist has to be receptive to the fusion or merging of different specialized functions. For example, I have a very active practice doing ultrasound-guided fine needle aspiration biopsies. I have had to act as a radiologist in that capacity. I've had to learn how to interpret and read an ultrasound, how to be able to translate what an image looks like in a CT or MRI to the ultrasound If the image was initially identified in an MRI, but the patient is having his biopsy directed by ultrasound, then that translation has to be accomplished. So the fusion of specialties is quite important. The pathologist has to really understand what the endoscopist sees during the endoscopy procedure. I utilize images from the endoscopy in my surgical pathology report, not only for annotation purposes, but also for patient education. We really have to intuitively shift the focus from a diagnostic sample to the complete patient. When I was in a hospital practice, it was my purpose to make rounds on patients scheduled for frozen section so that I could introduce myself, explain what the pathologist was there to do for them, and actually to engage them as part of the healthcare team. And I had a great deal of satisfaction and patient feedback that this was something that was very important to them because they didn't know what they were being subjected to, they didn't know what the outcome would be, and they were feeling extremely grateful to have yet another resource whom they regarded as the ultimate resource for the explanation of those tests. Frozen section is a really good example. The evolved pathologist really has to be understanding and embracing of digital imaging, archiving, and telemedicine, not only because of the benefits of long-distance communication through imaging, but because imaging is such an important part of how the pathologist will relate to the small biopsies that we're going to be getting in the future that substitutes for large resections for the diagnostic side. So I think that it's very important that pathologists do not reject the idea of learning the technology behind images. Pathologists need to advocate for the image-guided fine needle aspiration biopsy performed by interventional pathologists because that actually puts you at the interface level with the patient. In my practice, and this has been not only fostered by but accepted by the clinicians, I have a private practice of fine needle aspiration biopsy in addition to my surgical pathology outpatient practice. But I also am the person who does all of the ultrasound-guided biopsies for a group of radiologists who own 4 imaging centers in the desert. And I also am a collaborator for 5 ear, nose, and throat surgeons, and I do all of their ultrasound-guided biopsies and actually expedite their practice because I'm doing their thyroids and salivary glands and meeting the patients and turning all of that around. It really works very well. Patients are self-referring to me. Patients are consulting me after the diagnosis has been issued. Patients are seeking out aspiration biopsy and contact with pathologists because we really do have the ultimate word. We tend to have a little bit more interest, those of us who are patient-oriented and who need to become patient-oriented, in being able to relate to the patient for the questions that they have about their health. So this is a fine needle aspiration biopsy that I've done. You can see the needle moving back and forth inside this thyroid nodule. And one of the most critical, and I don't want to play this down, but one of the most critical things that pathologists can do is amplify the surgical pathology or fine needle aspiration biopsy report to make it not only informative to the clinician, but educational to the patient. So my reports will include, in addition to all of the necessary diagnostic information, I will include images if it's an endoscopy report from the endoscopy itself, if it's from a fine needle aspiration biopsy, showing that the needle is in its target. This is for medical legal reasons, but mostly for educational reasons. When I complete an aspiration biopsy for a patient, I play back the digital image little movie so that they have an understanding of where the needle went, what was accomplished by it, and they find that fascinating and educational. But these reports are being used by my clinicians to actually do the consultation with the patient at the time that they are relaying what the diagnosis is. They use the images, they use the diagrams, they use the cartoons in order to explain to the patient what their situation is. And the patients are so receptive to this that it is now becoming a standard that they're requesting. I think that the future is ours to own. I think that if we break our own barriers in terms of contact with patients, refocus to the patient, human-to-human contact, verbalization, communication, interest, dedication. What you'll derive from that is not only a tremendous contribution, but a terrific sense of accomplishment, invigoration, and satisfaction. The California Society of Pathologists is very happy to have welcomed ASCP to California, and we share in this global attitude of taking pathology to the next dimension, and we really are your collaborators in this. The best way to predict the future is to create the future. It's all within our hands to be able to do that. I'm a pathologist like everyone else. I've just made the commitment to myself and to my patients that I'm going to be a physician first and a pathologist second. Thank you.
So what we're going to do, we're going to direct some questions to our panel, and then I'd like to turn it over to the audience and take some specific questions from you based on what you heard. Obviously, disparate discussions, some of it concerning, but I think it's important that we face reality and look at some of the alternatives that we can forge together, learn from our respective colleagues, and then take control of our own destiny. So I'm going to start off with the first question. And I'm going to leave it open to the panel who would like to pick this one up. Pathology and laboratory medicine, as you know, got started under the auspices of the microscope. And a lot of the clinical sectors, even outside the microscope in clinical medicine, emerged as one-off tests because the microscope could not do those particular, or fulfill the particular functions. Now, of course, in the age of molecular diagnostics and genomics, it's rapidly emerging, and you're hearing a lot about how these tests can best benefit the patient. But my question to anybody on the panel is, in an area where the emergence of a profession is mandating that we understand the science of molecular diagnostics and understand genomics in a very broad way, in a spectrum that's evolving quickly, how do we take control and bring those skill sets that are currently lacking in many of the areas of our pathology education, both at the resident level as well as our current practitioners? How do we bring those skill sets forward? And should those skill sets be part of the current paradigm of practice for our pathologists? If you're going to be part of a whole genome sequencing in the future, what are we going to do to educate our pathologists and laboratory professionals in skill sets that they don't currently have? All right, I'm going to pick on Dr. Stoller.
Oh, good. Oh, good. I was hoping you would pick on me. Because I want to turn the question around just a little bit. Because we talk, you heard 10,000 new tests. And I would say, yeah, there are 10,000 new tests coming down the road, and we can sequence the whole genome for maybe $1,000 or $500. But one of the processes that is inherent in the adoption of that new technology and that complexity is the conversation, not so much a conversation, but I think this is a focus of where research in pathology and laboratory medicine needs to go. If genetic sequencing gives the patient the right answer for selecting the appropriate drug or the appropriate therapy, so be it. But if a morphologic interpretation done by Dr. Cominski in real time at the patient's bedside can give you that same answer, well, I mean, that tension between the old and the new, as Dr. Tomaszewski, I think, is going to talk about maybe a little bit tomorrow. The more data elements, if we analyze the whole genome and think about what we're getting by analyzing 10,000 different results, the synthesis of that 10,000 results is often represented in the image we look at through the microscope. So I think the question is not, yes, we have to educate ourselves about the technology, but the critical interface for me and for, I think, all of us is the balance of what is the most cost-effective way to get the result that generates the data that the patient and the clinician need to have for the correct treatment. And the answer may not always be analyzing the entire genome and proteome as a superior method compared to some of our traditional methodologies. The challenge, of course, is not only how do we educate around the new, but how do we develop the database to allow us to make those optimal choices? Because you can't do everything, especially when one costs, if one test is much more expensive than the other.
So let me build on that a little bit. So if pathology needs to use a more holistic approach, blending, of course, clinical diagnostics and anatomic, but looking forward to, or looking ahead at the future of molecular diagnostics, and we're using all of the tests in order to inform and choose the best tests, who is going to make that recommendation? Who is going to work with the clinician? Who is going to help the clinician understand which test should be utilized? Is it going to be the pathologist, or are we going to defer that to another colleague in the clinical sector?
Well,
David?
I think it should be the pathologist, and I think the patient thinks it should be the pathologist. And I think that the more people become educated that pathology is at the center of this, and that we're the experts in understanding why the test is available and what the interpretation and limitations are of the test, that it makes more sense for the pathologist to be on that primary consulting team level at the inception of the testing scheme.
But I really want to hear from Dr. Bernstein and Dr. Brooks about that, because there's that tension. I mean, if you look at subspecialized medicine, one of the hallmarks of that subspecialty expertise is subspecialist seems to know what tests to order better than the average family practice doc or generalist. And part of the question then to me is who is the subspecialist of choice if general practitioners are really the primary interface with the clinician? Is it the pathologist or is it the subspecialist internist?
I'll pick it up. I think it depends upon what the type of test is for who to get it from. So we talked about the issue of proteomics in terms of, do you get it from a specialized lab or do you get it from a centralized lab source? And so the question is really who has the expertise to guide me as a primary care doctor for providing the care. I'll take one exception to one of the things you said, Dr. Cominski, which is about the role of the pathologist. I really do like your idea that you are the expert and you can provide me, the primary care doctor, with the information. And as we move to the patient-centered medical home, we have to think about the whole patient, not just their fine needle aspiration for the thyroid, but how that thyroid relates to all of their other medical problems. I would hope that I would be able to synthesize the information better for the whole patient than just focusing on this narrow area. So what I think would be extremely helpful for me is for you to educate me on it. It reminds me of when I was actually a medical student. I was in England, and I would go out with the oncologists at cottage hospitals at the time. This was out of Cambridge at Addenbrooke's. And we would go out to these hospitals about 30 miles out of Cambridge for consultations. And I was with the equivalent of a fellow, and we saw a woman who had recurrent breast cancer. And she wanted to know what the diagnosis was. And it was very interesting because the fellow wouldn't tell her. She was a Canadian immigrant to England, and he wouldn't tell her. And I was a med student, and I said to him afterwards, why didn't you tell this woman? Why didn't you talk to her? And he said, we're a consultant. We're not here to give the advice to the patient. We're here to give the information to the provider.
But I wasn't implying that the pathologist should be making that comprehensive analysis of what the results are. What I'm advocating is that the pathologist, understanding what the test menu is, if there was a consultation with the clinician to begin with, to narrow down the field as to what would be the most beneficial combination of tests, to give information regarding the presumptive diagnosis, that would make much more sense than the shotgun approach that's very expensive, with the clinician very often not really understanding the implications of some of the results that come back.
And that's where I fully agree with you, that's the advice that I need. That's the advice that I'm asking you in pathology to give us, to work there on the guidelines, whether it's going to be the one-on-one consultation or coming up with mechanisms when these tests get ordered and the results come back, that you can give me the information and we can design the systems so that when you send me that result back, this is the path that we should take. I'm a firm believer that don't leave it up to me even to make that decision. If there's a clear path that we should do, we should just try to automate it.
So I'm sensing that there's an open mind to a forged role, a clinical forged role of pathologist as a consultant. Is that what I'm hearing?
That's my view on it.
And is that something that, do pathologists and lab professionals possess the skill sets to actually have that kind of clinical interface? Or Dr. Brooks, is there something that, what kind of seeds of wisdom can you share with us in terms of forging ahead?
Wanted us all to go overseas.
I mean, the obvious answer to that question is it's a shame that there's not pathology leadership to address these questions with real data and real studies.
Okay.
I mean, I'm a geriatrician. I believe that every person in the country who's over 65 needs a geriatrician, because I believe that getting up in the morning is important, and I go to work and it's hard, and gee whiz, I must be doing something valuable. You ask a bunch of pathologists if they should expand their role, the answer is going to be yes. You ask a bunch of internists if they can take care of the problem, the answer is going to be of course. I think we need some hard evidence. Now, I will say something that everyone has to really begin to look at. The first question is that the revolution that we're going through, and it's a revolution in molecular biology and genetics, can actually destroy all the healthcare systems in the world. Most of the policy people in the field believe all the solidarity is going to be destroyed because it's going to make medicine so expensive that no healthcare system will be able to afford it. And not will only we have two-class medicine, we'll have 100-class medicine. We can go through whether that's going to be the scenario or a different one is going to be the scenario, but that's the first issue. The second is that as technology matures, you don't need the artist. So if I really get a hip joint that is easy to put in because the manufacturers finally have figured out how to do it easily with glue that holds and wires that stick, and it becomes really easy to do, my tools are much better, then the training of the person putting it in can go down. That's just a fact of the technology revolution. As these tools, which are now being introduced over the next 10 to 15 years, become far more precise and known, I think we're all going to be replaced by a computer. I mean, and I don't even know if the hand of the person is there. So we now have mail-order pharmacies where a pharmacist sits there trying to figure out their role. The machine can count out the pills better, is more reliable in getting the right pill in the right bottle than the pharmacist is. Why do you need a pharmacist playing this role? Get the pharmacist to do something different. I really like the notion that we're all doctors. And if we're all going to medical school, you know, my future vision is that all of us have to find a role that will allow us to get more value for the patient care encounter. And I think it will be some mixture of all of this, but I don't know what it's going to look like, and I want some pathologists to actually be the ones that design these studies and are involved in them so that they're not biased, since they're all designed by Steve Bernstein as an internist.
So,
and I would just, Blair,
everybody
like
hear that?
Just
yeah,
add
Jeff,
one
please.
point. I think that you want to make this decision. You do not want government to make
Correct.
this decision.
You want physician. There is nobody in Washington, I mean, and you don't want social scientists. I mean, you need their help, and they need to be part of the teams. But the reaction to the stuff that I write about physicians taking leadership roles in this field is the answer is mostly, I don't give a darn, let somebody else do it, it's too frustrating, you know, nobody knows what they're doing, blah, 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 blah. If you leave the field open to everybody else, you'll get what everybody else thinks is important to do. Yeah. Physicians will phrase questions differently than non-physicians and provide value in this debate we're going, but there needs to be trained leadership in the field to do it.
Right. I'm going to take questions from the audience here, but before we do, I want to make a comment about that particular entity. The Agency for Healthcare Research and Quality, AHRQ, has said there's literally virtually a paucity, or it's an anemic response from the pathology community to do comparative effectiveness types of research, do the kinds of projects that will spawn out the data that's necessary for us to govern, you know, the future of our profession, et cetera. We obviously need to step up to the bat as professional societies. We need to galvanize our particular colleagues and our federated partners. But you have any advice on how we can begin to work together to jumpstart these issues? Because you're going from 0 to 60 at this point, and we're not even moving.
If you look at the initial beginning of this field, it was all made up of internists. And then the surgeons finally decided that having internists tell surgeons what to do did not really, result in anything that the surgeons felt was useful, or at least they weren't willing to accept it.
Right.
It really is time, and there are programs now available and fellowship programs. You have got to do something to say that some of your best and brightest in the field of pathology have got to go on to get the kind of skills, stay in pathology. You've got to hire them. You've got to develop the infrastructure, all of which the chairman of pathology has not put a nickel in. I can only tell you that there are very few heads of radiology, pathology, that have recognized the need to produce infrastructure and funds to develop successful careers for these people in academic medicine. The surgeons have now done it, and they are now seeing enormous value from doing it. The internists have done it for a long time. It's a fundamental sea change in the way academic departments have to function. And I'm sorry to tell you that, but there are none of you out there that actually can compete with Steve Bernstein for a comparative effectiveness grant. That's a shame.
Well, it's our job to step up and do that. We're going to take questions, please. Yes, Dr. Hilborn.
Dr. Holliday.
Yes.
Thank you all for actually a very interesting discussion. And as I was listening to this, and one of the things that you said, and you actually came back to it as I came here to ask my question, was how important it is. What role can ASCP play in terms of leading the efforts of our specialists, pathologists and technologists, to be at the table? And actually the question or the issue that Bob raised and suggested, for example, that none of us could compete with Steve, maybe we could compete with Steve, but what I think that we learned by working as a team within laboratory medicine, how important it is that we need to work as a team as laboratorians and others. So when that grant is due, what I'm going to do is I'm going to collaborate with Steve rather than compete with Steve. But I think that the broader issue as we work together is how important it is for us to work with clinicians, with nurses, with other allied health personnel, with the government, with the payers, and others who are setting standards to come together, because in fact we don't need adversarial relationships. What we need is collegial relationships. And how do we work together? And I think the question that I would like to discuss is what role or what ways can ASCP really facilitate our profession being part of those collegial interactions?
Is the question directed to me or one of your panel members?
I'd let anybody take it.
Okay, Dr. Stoller, would you like to take that one?
I think the best way to facilitate the conversation between the specialties is for pathology to do what we've been talking about, to get out from behind the microscope, get out from the laboratory, go out and talk to the Stephen Bernsteins of the world, the Bob Brooks of the world. ASCP is developing, and we've talked about it many times, the infrastructure to facilitate that conversation. The Institute for Health Services Research is exactly what Dr. Brook, I think, was alluding to. The ability to not only develop the data, but to help train the next generation of pathologists to be able to bring out that paradigm of developing the best, in simple terms, the right test for the right patient at the right time, based on data, not on just opinionative or cost.
But I'll just follow up on that, which is just that's the way these other societies and other specialties developed. They began, just like you're saying, that American Society of Clinical Pathology is developing your Institute of Health Services Research. When the American College of Surgeons wanted to do this, they got together with either ECRI or RTI or RAND or other organizations to begin developing it because they didn't have that infrastructure. So they, as a society, did this, but then they began having their fellows, their students train and learn this as part of the profession. So I think it's really a halfway technology to be working collaboratively with these other groups till you start building up your own, capacity.
And indeed, these models that American College of Surgeons, American College of Physicians have already done, ASCP has already been talking to those. We're very much not about reinventing the wheel. If there's a known way to get to the end game being able to meld together the new 10,000 tests, the molecular diagnostics, the proteomics, et cetera, with patient-centered care in a way that keeps us all involved in patient care the way Dr. Cominski has described. That's really it's a long-term effort, but this is really where ASCP is going.
One of my big concerns, though, is that the evolution of technology is going to be a distraction away from that direct patient care focus, because it can't be for everybody. It's not affordable, it's not practical, and it's not something that everyone needs. What everyone does need is that personal touch that I'm advocating. And so there has to be a balance struck between those. And I think that in terms of education, I think societies can make innovative changes in the way education is brought to pathologists. But pathologists have to, number one, be receptive to change and not be so complacent. And number two, some of the traditional ways of delivering education in residency programs, in cytotechnology schools and so forth, have got to really get out of the tradition and into the innovative.
And yet I would just point out that one of the great benefits of technology is that technology can facilitate patient care. I mean, as you said, you used to have CT-guided FNA. Now most FNA is done by ultrasound guidance. Molecular technology is if nothing else, no different. I mean, molecular tests that will require highly skilled PhDs with magic hands now are, in cassettes, in machines that we can bring to the bedside. There will be a time in the not too distant future when molecular testing could be point of care.
We're going to take some more questions, but I think it's interesting, and I don't mean this to be a cliche, but you think about the double helix. You have to have the intersection between clinical care and clinical skill sets and the technology. Both of you are talking about that, but weaving those patterns and educating our profession to be skillful in both of those is going to be crucial. You had a question.
My name is Nilesh and I'm coming from Stanford. My question is, do you envision any national health information system where a patient gets a national MR number, so anybody within the US, especially the physician, can get the information at any place so that we can decrease the redundancy in terms of testing and procedures?
Are you asking about the residency program? Is that what you said? Or?
No, like for the health information systems. So
okay.
Do you envision any nationalized system so that a patient gets a national MR number? So being it anywhere in US, we can get access to the information.
I mean, I'll just address that. I think it's a great idea. I think one of the problems we've got as a society is a national identification number, that there's a lot of concerns, I think, within our society about Big Brother or others having this ability to follow us. I think it makes perfect sense. It would answer the question I had about being able to just link all these pathology tests. But even now, when you look at Medicare data, Medicare, if someone doesn't work, their spouse may end up having the same number that they've got, and then you need to do linkages to try to figure out who the patient is based upon date of birth, gender, number. So that would be an ideal solution. It's a question whether it would get through HIPAA and the politics.
I hear bioinformatics. I hear the need, the necessity for engineering more of a molecular genetic approach into our residency program. I think we're beginning to design a new paradigm here. I think the organization is clearly positioning itself to take a proactive leading role. I believe it's important that we work together with other organizations to make this happen. In fact, we are looking at federated models so we can all complement this and advance the future of pathology and laboratory medicine. Unfortunately, we're going to have to wrap it up there. I want to thank you very much for coming. Give the round of applause to our panel.